We're going to do some different cases. I have a couple more of my own that I would like to go through with you because it illustrates many other points of intersection between pathology and clinical ophthalmology. And then I'm going to do a number of the cases that you requested. Now, some of the residents came up to me and asked me, and I must apologize in advance, asked me to do some things with the eyelid. And I was thinking about this. In order for me to really do the eyelid properly, it takes me about, it's a whole morning. It's about 2 hours. And I can't do it simply. So for the residents who asked me to do this, you have my apologies, all right? I'm going to try to do some things that are simple and quick that we can go through. And if we will have a little extra time, we can take another break and maybe we can squeeze in some eyelid cases. Is that okay? We'll see how fast we can get through. I forgot to show you something about this case. A little curiosity. If you come out to the periphery of the retinal detachment, right out over here, I want to make sure I showed this to you before we left this case. You have a very interesting small finding. You can see the pars plana, you can see the retina, and where the retina terminates its detachment, you have an interesting lesion, a little nodule. Inside the nodule, you have proliferation of retinal pigment epithelium. Now, before we were talking about the difference between retinal pigment epithelial hypertrophy, the enlargement of an individual cell, and hyperplasia, an excess proliferation of cells. I would classify this as retinal pigment epithelial hyperplasia. And also you have fibrous metaplasia of the same thing, forms a little bit of a nodule. What color, because of the presence of the pigment epithelium in there, what color do you think this elevated ridge would have looked like? It's pigmented. We're looking at the pathology of a demarcation line. Now it turns out that because I was told there was a retinal specialist in the audience, so I need to talk a little bit about retinal pathology and extra. It's a pathology. Now this has a particular name in ophthalmic pathology. It's a peculiar German name. It's called a Ringschwili, kind of a funny name, which is a little proliferation of retinal pigment epithelium at the terminal margin of a retinal detachment. But because we had a request for a little extra retinal pathology, I would at least show you what a demarcation line looks like. You know, I would like to do a very, very quick case for you, just a little bit to review. It will take us just a moment or so. Again, if you were doing gonioscopy on this particular eye, would you have been able to see the scleral spur? Yes, no? No? All right, so we need to find out why the angle is closed. And very, very quick case. We'll come up over here. We will look again at this case. And you can see it looks like the angle would have been closed, but in fact it was just narrow. You see it? Coming back in here like this. Well, let's look at another case. And I would love to go over this case with you. Now, I'm going to walk down here, and I would need to cover a lot of things quickly because so many of you requested so many different cases, and I want to try to get to them. But this case is spectacular. I love it. Okay, first of all, I want to point out to you, and I'm going to go to the back of the room so I can be with some of my friends who are, my goodness, so far back. I want to point out to you that this business that you see where the cornea is bent in, that's an artifact. Okay? We're finished with this? Done. I want to point out to you what is this structure here and this structure over here. Do you know? Anybody have any ideas? Muscle. The muscle. Which muscles? The rectus muscles. Now, I want to point out to you, and I always talk about this because now you'll understand why I'm not a surgeon. Yeah? Yeah, because I want to point out to you that the sclera posterior to the insertion of the rectus muscles is extremely thin. Very thin. And when I trained in ophthalmology, I had a problem. I had many problems in training in ophthalmology. But I am very dominant right-handed. The only thing that I can do with my left hand is accept my paycheck. You understand? And so I had a pediatric ophthalmologist who insisted that we do bimanual surgery. And I was very clumsy with my left hand, and I'm a pathologist, and I also knew that the sclera is very, very thin, posterior to insertion of the rectus muscle. And so when you do a muscle recession, you are putting a suture into a very thin area of sclera, anatomically. And he kept telling me with my left hand, go deeper and deeper. And I said, but professor, you know, I mean, the sclera is thin. The next thing he did, he called for the indirect ophthalmoscope, you know. So this is a reason for the pathologist. This means I made a mistake surgically. There's no harm to the patient in this case, but now you won't know this. Now, I want to point out a couple of other things here in the general landmarks. The first thing I want to point out to you is there is a position of muscle that is located over here. And that's going to be very important because it's going to launch us into a long discussion. Not too long, you don't have to panic about it, but people ask me to talk a little bit about the macula. Which muscle is that? That is the inferior oblique. All right, so the inferior oblique inserts into the sclera without any intervening tendon. Now, what I really want to ask you is, if I were to draw a line from the insertion of the inferior oblique into the retina, where would I be anatomically in the retina? In the macula. Yeah. You know how I always remember this? I don't know if Kobe Pe'er remembers this story or not. My youngest son was born, Ephraim, Effie, was born the very same day as Doron, right? Kobe's son, a couple hours apart, different places. I was in Iowa, Kobe was in Yerushalayim. And so my son is 5 years old, and he is preparing for GAN, for kindergarten, and they take him for an eye test. And he comes back from the test. My wife is not a physician. She's in information technology, she's a mathematician. And she called me up at home, and she said, Effie failed the eye test. Oh, what's the problem? It said that he has aphoria. Aphoria. So I tell her, well, everybody has aphoria. What are you for? I explained to her. She says, you know, it's not good that you should take care as a physician of the children. I take him to see the pediatric ophthalmologist. So he went to see a very, very famous pediatric ophthalmologist at Iowa. Those of you who are in pediatric ophthalmology will recognize the name, Dr. Bill Scott, a very famous pediatric ophthalmologist. Bill called me in the office. He says, Bob, you don't know very much about muscles. I said, this is true. What are you going to teach me? He said, how long has your son been tilting his head to the left? I said, I always thought that he was very cute. Besides which, how many of my friends are ophthalmologists that saw this child since he was born, tilting his head to the left? Nobody mentioned it until now. So, okay, so he needs to have a weakening of the inferior oblique. And so that's okay, I don't have a problem with any of this, except that the pediatric ophthalmology fellow kept visiting my office often, hanging around my office. I knew exactly what she wanted. So finally one day, I said to her, Elizabeth, that's not her real name, but I'll make it up for you, okay? I said, Elizabeth, anatomically, what structure sits beneath the insertion of the inferior oblique muscle? She said, the macula. I said, that's a very good answer. So I tell you what, I'm going to answer the question you are about to ask me. You can do the case on my son, you can do the surgery on my son, as long as the attending is in the room. It's okay? All right, so you need to know a little bit about the anatomy of the area, and I'm going to show you why that is so important. Now, here's the next thing that I want to point out to you anatomically, and this is very, very important, because we're going to get into a little bit also of optic nerve pathology. Let's do this for just a moment. Where are the cells of origin of the axons that go through the optic nerve? What are the cells that originate the axons of the optic nerve? They're called the ganglion cells. So this is the ganglion cell layer of the retina, and they generate the nerve fiber layer. It's okay. All right, great. Now, I want you to do the following if you can. If you can just look up here for just a moment. Okay, I'm going to give you an up because some of the residents said they're new and they're studying for examinations. So with your left hand, make a circle like this. Yes. Into the right hand, put all of the fingers and your thumb. We call this a normal optic nerve, and all of your fingers, you can see you can't fit them in. It's very tight. The reason I mention this is the optic nerve itself is attracted to the central nervous system. It is surrounded by a dura. Okay? And usually you do not see a widened subdural space. I promise I will come back to some pathology for my pathology colleagues. Okay? In the brain, if a patient has cortical atrophy, let's say from long-standing Alzheimer's disease, and you do an MR scan of the brain, what do you see in the imaging studies? What happens to the subdural space of the brain